Good afternoon, everyone, and welcome to PiXight, our webinar series on imaging and AI innovation in rheumatology. My name is François Bonnet. I am a scientific program manager at the Medical University of Vienna, and I'm your moderator for today's webinar. Today, we will explore the fundamentals of imaging in rheumatology and the role of artificial intelligence can have in empowering these methodologies. But before we begin, a quick reminder for our audience. If you'd like to ask a question, please post it in the YouTube chat. We will address as many as possible at the end of the session. I'm delighted to welcome today our two outstanding guest speakers. First, here with us today is Irina Gessel from the Division of Rheumatology at the Medical University of Vienna. Irina is a rheumatologist and postdoctoral researcher who focuses her clinical work and research on patient imaging techniques and the influence on psychology on rheumatic disease progression. I would also like to welcome Jana Eder, who is a junior PI and an AI and imaging expert also working at the Division of Rheumatology here at the Medical University of Vienna. We are all Viennese people here in this episode. Jana's work focuses on leveraging artificial intelligence to improve the interpretability of patients' images, which is the core aim of the AutoPiX project. Thank you very much, Irina and Jana, for joining me for this episode on the fundamentals of imaging and rheumatology and the role of AI.
Thanks for having us.
Without further ado, I would like to start now by asking my first question to you, Irina. Irina, from a clinical standpoint, how central is imaging today in managing inflammatory rheumatic diseases?
Hi, first of all, thank you, and I'm also happy to be here. So it's very important. We want to know as much, we want to gain as much information as we have to optimally treat our patients. And what we can do, we can talk to our patients. How does this pain feel like? Where is it? We can look and we can touch the patients. Do we feel something? Is there a clinical swelling? But in many situations, there are just limitations. We cannot see through the skin, and especially, for example, in the spine or the bones, we just cannot see it. So it's very necessary, useful, and helpful, and a very important aspect in my daily life as a rheumatologist.
Thank you very much, Irina. From your side, Jana, what makes this field of rheumatology particularly interesting or challenging for an AI researcher like yourself?
I think medical data and especially medical imaging contains far more information than we maybe just can see or have time to look at in routine care. So AI can help turning existing information or existing scans in more information provided for the clinicians and help making better decisions.
Mm-hmm. Thank you very much, both of you. I'd like to now take a little step back, maybe because people might not be in the audience, might not be familiar with the main imaging techniques that are currently used for monitoring or diagnosing inflammatory rheumatic diseases. And I would like to turn back to you, Irina. Could you walk us through how you use these techniques? So I'm talking about ultrasound, MRI, and maybe X-ray in your daily practice. And an additional question I have attached to this one is when do you decide on one modality over another for a patient?
Yeah, so there are some aspects the patients might see themselves. For example, ultrasound can be used immediately. So more and more rheumatologists perform ultrasound themselves. And it's a dynamic examination. So you can really, the patient tells you, my pain is exactly here. And then you can exactly look at this point. And for other modalities like X-ray or MRI, you need an appointment at the radiologist department, and then usually the radiologists will analyze these images. But then there are also other differences. For example, the X-ray, what you can see mainly are the bones. So you cannot see tendons, you cannot see is there inflammation, you can see bones, which is also very useful for us. For example, you can see fractures, or in our case, for us rheumatologists, you can see structural damage, such as erosions and other aspects that we want to prevent actually as rheumatologists in our patients. And then MRI is very useful to detect also structures like tendons, and we can see synovitis. So it's just different structures we can see. So it depends very much on what we want to see. And then ultrasound has a very special role. I already told you that it's like very cool, let's say, for us, that I can do it on my own. I don't need the radiologists to tell me what they see and so on. I can do it on my own. I can do it immediately. So the patient comes here to the appointment, I can do it immediately. And I can see both. So I can see inflammation in the joint itself, like synovitis. I can see inflammation in the tendons. I can see also, for example, ruptures in the tendons. But I actually can also see the surface of the bones. And I also can see, for example, erosions. So to summarize, it depends very much on what I want to see. Is it the bone structures or is it different structures? And then also, like, how fast do I need the information and how, yeah. And then also there's another aspect. This was like the clinical point of view, but then also there's another point of view for studies, of course. So often for studies, for clinical studies, if we want to assess how does this new treatment work, one potential outcome could be the patients with this new treatment, do they have less structural damage than the other group? And yeah, and here we also need different imaging modalities, and then it might not be feasible to perform ultrasound. Yeah, so yeah, maybe a little too long answer, but you see, it very depends on what you want to know, what you want to see, how quick you want to have it. Do you have time to perform ultrasound? Are you able to perform ultrasound? And is it for your clinical point of view or for studies?
Thank you very much, Irina, for this very detailed and granular answer. And I can imagine in your head there is like a tree forming and leading up to all these decisions at one point or another. Anyway, it's again such a pleasure to have both of you to talk with so much enthusiasm and passion about your work. It's great. Anyway, I would like to continue to towards more maybe. Bridging, sorry, I was lost in my prompt here. I'm sorry, I just caught up. I just would like to now switch to challenges in current practices of imaging. So you clearly detailed that it is not an easy decision to decide on one technique over another to monitor or to diagnose the patients with imaging. But could you tell us more about challenges that you encounter while you are trying to apply those techniques to the patients? More specifically, what would you say are the main limitations you're facing today? Is it a lack of time, a problem of accessibility of the patients to the right machines, or is it a problem of interpretation of when you actually image the patients and you want to make a conclusion? Is it the variability that the machine has inherently? So how much does experience influence what you see in an image? And do you ever feel like that two experts that look at the same image would interpret the same image differently?
That's a very good question, very, very important question. And all of your suggestions were correct, actually. So one limitation you mentioned is the inter-rater reliability. What does this mean? Exactly as you suggested, rater 1 sees something else than rater 2. Yeah, let's say rater 1 is very cautious, yeah, and wants to detect each single erosion. And sometimes there are like doubts, is this already an erosion or not? And then rater 1 would say, yes, that's an erosion, and rater 2 would say, no, that's not an erosion. Yeah, so we call this inter-rater reliability, that it very much depends on who examines these images, that the results will look differently. So that's really a big aspect, and that's also why in every study we do or in many studies we do where we include imaging, we always assess inter-rater reliability if there are different raters. So we want to assess how big is the difference between the raters? And in case this difference is very big, this is a problem, and we have to talk again and to decrease this. But of course, that's a huge topic, and also for studies, you know, yeah, that's also something very important. Then feasibility. I already told you that ultrasound can be usually performed immediately, but what does this mean? Yeah, us as rheumatologists, we need to have time. Yeah, and I think everybody with a rheumatic disease knows that time is usually limited. So I don't think that many patients have the feeling that they have hours for each appointment. So time is very limited. But it's not only time, it's also the machines, for example, and also experience and knowledge. So of course, it's a training. You need to be trained in order to see things. So you have to be trained. And then also for other imaging methods, you need a time slot, yeah. And then, for example, for X-rays or MRIs, and yeah, it depends on the hospital or where you do this. There might be weeks or maybe sometimes even months until the next 3 appointments. And then the radiologist will analyze this. And then sometimes I have questions, you know, so yeah. Yeah, did this answer your question?
Absolutely, Irina. Oh, yeah, sorry, we had some echo. Yeah, absolutely. Thank you so much, Irina. This is very much in line with what I expected as an answer here. Let's move on. I think it's a perfect time to actually move to the topic of artificial intelligence and how potentially artificial intelligence could potentially lever new possibilities to help with these challenges. And then I have a question, of course, to you, Jana. From your perspective as an AI expert, where do you think AI has the most immediate potential in rheumatology imaging? Is it about detection, improving detection, quantification? Is it about helping standardization, or is it about helping workflow support, or something else? Could you tell us more from your perspective, Jana?
I think there are like several answers here. So one, of course, is going to your and Irina's point, is that we have like a very wide inter-reader variability or even inter-reader variability. So if the same person reads the same image or performs the same examination on a different time, they may come to different results. So what we want to do is we want to get a more objective, more standardized measurement. I think this is especially important in ultrasound. And also what Irina told us already is that ultrasound image is the one thing we can get like immediate access. So this is what a physician can perform like immediately. So this is a lot of potential here to improve this. And what we can do, actually what AI can do, AI can take specific tasks and this can perform this task like 1,000 times better, faster than humans, but only specific tasks, not the whole workflow. So you have to find the right place in the workflow where to integrate it. And where do I see the most potentially is currently on early disease detection. So like if you detect a disease, yes, which is like going worse and worse over time. So it's very important when you detect it. So what I hope what we can do is like really improve the whole patient care in a way that the disease is detected earlier, that the right drug will be found in an earlier way. So this will actually improve the quality of life of patients like in a very tremendous way. So this is actually where I see the most potential right now.
Thank you so much, Jana. And indeed, it's good to have a more concrete example of how AI could actually help the work and the life in general of patients with rheumatic diseases, but also the clinicians' work. And this is where I want to go next, actually, in terms of if this would work perfectly. Let's say Jana could come up with a perfect solution that would allow early detection of rheumatoid arthritis. What would it change for you, Irina, on a typical like, let's be concrete. For you on a typical clinic day, would it save time? Would it improve confidence you have when you're talking to a patient? Would it actually change treatment decisions that you would have been made otherwise?
I think so. I'm very optimistic and positive that AI will help us in many ways and will solve many problems I already mentioned, or we us all already mentioned. I think one aspect is already that the medical or also the rheumatologic community, scientific community, we have to discuss how we want to incorporate this. So for example, let's take the example of early detection. I think this is very important, but then of course, as a second step, we have to assess, so what is the best solution? How can we incorporate this in our daily business? So of course, not everybody should receive an imaging, so it should receive ultrasound to potentially early detect RA, but we have to find, for example, diagnostic criteria who will receive these images. You know what I mean? So I think, yeah, AI will help us a lot, but then we also, as a second step, we need like rules how to incorporate this. Yeah, but of course, like in my daily practice at the moment, it would help me very much if for example the diagnosis or if the examination is done very quickly, and if I have a result on this imaging method which is reliable. Yeah, so I know that's true. I know that's it every time the same. Yeah, so I do not have to second guess it. So this will be very big help in my daily clinical practice.
Thank you so much, Irina. I think it leads us perfectly to the next theme that I want to bring up, since I can see that the time is ticking and we are a little bit running out of time, but I would like to touch upon trust and adoption for artificial intelligence. And this is what we're talking now in rheumatology, but I think it's a broader topic about how we trust and adopt artificial intelligence in medicine in general. Because as promising as AI sounds, the adoption of AI is never straightforward, and probably for good reasons. Irina, what do you think would be the most important thing you would need, or what would any rheumatologist need to fully trust an AI tool in their daily practice?
So what I do is evidence-based medicine. What does this mean? Medicine based on evidence, and evidence means studies. So I trust studies that are well performed. There should be several studies. So I think that's the most important things. We just need studies like AutoPiX are conducting. And then, of course, the other aspect is the regulatories, like data protection and so on. Yeah, I think these are the two main aspects I need to trust this.
Thank you so much, Irina. Jana, from your side, what are the biggest barriers that you see today from your side as on the AI side, I guess? Is it about data quality regulation? Is it about data integration, or is it something completely different?
I think it's all of it. So it's definitely data quality, because we have different scanners like on different hospitals. And so we have to like combine all this different data. And if our AI works in a perfectly predefined data set, then we don't know if it will work anywhere else. So we have to prove it. And also, I think this is very important, what Irina just said, is that a medical doctor has to see that we can perform studies. So whatever we want to do with this, we have to show that we can do it in the same way as humans can do it. So we have to reproduce a lot of clinical studies with our AI system. And I think the last one you mentioned is definitely integration, because what does it help if we have the greatest tool in the world, but then we need like an extra step and it's not really integrated very perfectly in the workflow. So in order to save time, we actually have to find the perfect spot where to save time.
Thank you so much, Jana. I have one final question before we reach to the conclusion of this webinar, and it's a question for both of you, and you can decide who wants to answer first. What would success look like for you, let's say in the future, if something would have happened in terms of breakthrough in AI and jointly made in AI and imaging in rheumatology that would make you say this really changed the field? What would success look like in your opinion?
You
Who
want
wants to start? Should I start? Okay. Okay, I have to think about this question. How would success look like? So a clear improvement in my daily clinical practice. Yeah. Feasibility. So that maybe I'm able to spend more time, that AI helps me spending more time on each individual patient, or that I can have appointments quicker for patients. Yeah, so clear reduction of time I need, and then also higher reliability. The trust is higher in the results. I think these are like the first two aspects that come into my mind.
Thank you so much, Irina.
Yeah, so I think if the right patient is identified and treated with the right treatment, and we are able to increase the number of patients we can care for, I think then we have done a good job, definitely.
Super. Thank you so much again, both of you, for having shared your insight and your expertise on this topic. I learned a lot today, although I have been involved in this and embedded in the AutoPiX project for now several years. I think it was fantastic to have those two visions next to each other. It felt more like you are working together rather than real confrontation, but very much inspired by what you said today. This brings us to the end of this episode, but before we close entirely, I would like to just quickly check in the chat whether we had questions from the audience. You had the opportunity earlier to ask any question, but I believe that there is no question. I think otherwise I would see them in the chat right here. If not, you can always ask these questions on the YouTube. Yeah, no questions. I got the confirmation from Loreto, all good. You can always ask these questions in the comments of the YouTube video, and we will also try to answer them there if you feel too shy to ask them right now. Okay, we hope you gain valuable insight into the fundamentals of imaging in rheumatology and the role of AI can have in empowering these methodologies. Please stay tuned for our next PiXight episodes. And
one question.
Oh, we have one question. My conclusion, my outro is being completely ruined, but I think it's for a good cause because I believe this is the very first question we've had on this series of webinars. So I'm willing to wait a little bit while Loreto is typing in the question. The question is, what about the perception of AI in medicine from the patients? So I guess it's maybe a question for you, Irina. How do patients perceive AI being more and more included in your practice?
So this is a very important question, and this aspect is considered in many studies, in, let's say, almost most studies I read regarding AI in medicine. And I mean, it's hard. I don't have like a complete overview over the whole study situation, but I'd say just like from many studies I've read, the perception is better than maybe some people would assume. So they're really open. There are studies that the majority of patients already use AI on their own for medical questions, like discussing medical questions with ChatGPT, for example. So many patients already use AI. And then there are interestingly also studies on the perception, for example, of patients who were chatting to either real doctors or ChatGPT. And the results are almost sometimes embarrassing for doctors, let's say, because some of the studies also assess the empathy. And it's really not, the results are not that doctors are significantly better. So the perception of patients regarding AI is very, very important and will be included also in many studies performed on AI in patients, in people with rheumatic diseases in AutoPiX. Yeah.
Thank you very much, Irina. Maybe let me extend this question to you, Jana. How do you, as an AI expert, engage with the public to try to also make progress into the public understanding and maybe not fearing necessarily progress for AI used in medicine, AI used for the purposes of human, for good purposes, I should say, in a very naive way?
So I try to rephrase the question because I might not fully understand or understood. So so basically, you want to ask like, how do we like include AI to make sure?
My question is really, have you already engaged in a public setting to explain for example, the more, I mean, obviously this is part of what the answer of this question is right here in this webinar, where I'm just wondering if from the side of AI expert, is there really a motivation? Is there some impulse to get out there and talk to the general public and say, hey, explain to them what you're doing and try to have a conversation with them to reassure them and to maybe make them more trustful in potential new innovations that could come out of your work? That's where I'm going.
I think it's a really good question. I would say I see it from a slightly different perspective, because I think it's definitely important, but I don't think it's important that I go out there and tell anyone anything. I think it's very important that I go out there and listen to the patients, understand what they need, understand what makes us trustworthy, and then design the AI in the right way. So I would see it this way around.
Fully understood. Thank you so much, Jana, for completing my very ambiguous question. Okay, I think this time, I don't think we have more questions from the chat, at least I cannot see any. Yeah, let me restart my outro. So we hope you gained valuable insight from this webinar. Please stay tuned for the next PiXight episode. I'm not sure exactly when it will be, but usually we try to keep a pace of one every month. Follow our social media channels if you want more up-to-date, more frequent updates on our progress, and our website as well, where you can find our most recent publications among a lot of other resources. With that, thank you again, Jana and Irina, for this amazing webinar here, and I wish all of the participants and you as well a great afternoon. Thank you for being part of PiXight.
Thank you so much for the moderation.
Bye.